Hi, and welcome to another episode of CRC Health Connect. I'm your host, Dr. Siu-Him Chan. We're thrilled today to have Dr. Amlani, our newest rheumatologist at CRC Health Centre, joining us today on this frigid morning. Welcome, Dr. Amlani.
Thanks for having me. I'm excited to be here.
I'm sure this weather is nothing to you compared to Ontario.
Oh no, I'm from the West Coast, so I have delicate West Coast lungs like the rest of us.
Nice. So
Yeah.
Dr. Amlani is a FRCPC certified rheumatologist. He has also a special interest in palliative rheumatology. He's now working in Richmond, BC. So Adam, a lot of us refer you guys for patients with joint pains. And the most common diagnoses are osteoarthritis and rheumatoid arthritis. And we certainly don't know a lot about these diagnoses. Could you tell us more about that?
Sure. Yeah. So I think Dr. Kazem may have done a previous segment on osteoarthritis, right? Um, so,
Osteoporosis, I think. Yeah.
oh, she did osteoporosis. Okay. So osteoarthritis is the type of arthritis that you get as you get wiser. So, as you've been using your joints a lot, you start to lose joint space and you start to lose cartilage, and because of that, you start to get pain. So that's a non-inflammatory process. Whereas rheumatoid arthritis is an inflammatory kind of arthritis. And what that means is your immune system that normally fights off infections actually starts attacking your own body, in specific, the small joints of your body. Most commonly, it'll be the joints of your hands, so this row of knuckles and this row of knuckles, or the similar joints in your feet. And so when you have rheumatoid arthritis, the goal is to control your immune system so that it stops attacking your own body, and that's how we treat people.
Mm-hmm. So how do these patients with rheumatoid arthritis usually present?
So people with rheumatoid arthritis will often come in with pain in the small joints of their body. And when they have rheumatoid arthritis, the type of joint pain that they complain of is very characteristic. So they'll complain of a lot of stiffness in the joints in the morning. Usually it's more than 30 to 60 minutes of joint stiffness, which tends to get better as they move their joints around. They'll also present with a lot of swelling in their joints. So their joints will get really puffy. And because of that, they'll start to lose motion in the joints that are affected.
I see. So when these patients get referred to you, what's your usual sort of algorithm in making the diagnosis?
Yeah. So when someone comes to me with a question of rheumatoid arthritis, usually what happens is I'll ask them a few questions to see if I can tease apart whether their joint pain is more characteristic of something like rheumatoid arthritis or more characteristic of mechanical joint pain, such as osteoarthritis. And so some of the questions that I'll ask them are, which joints are involved? How long have they been hurting? Is there any swelling in your joints? Do you have trouble making a fist in the morning? Do your joint pains get better or worse with movement and better or worse with rest? Typically, people with rheumatoid arthritis will tell me that they have swelling in their joints, their joint pain gets better when they move it, and it's worse when they rest. Whereas people with osteoarthritis will tell me the opposite, where the joint pain gets better with rest and worse with movement. After that, I'll do a physical exam, and what that would entail is a head-to-toe exam, but focus specifically on things that I'd look for in autoimmune disease. So it would involve a head and neck exam, a cardiovascular and respiratory exam, sometimes a focused dermatologic exam, but most importantly, a joint exam. And when I'm doing a joint exam, I'd look at the range of motion in the joints, I'd look at how the joints look, and then I'd feel the joints in particular, looking for swelling or something that we call synovitis, which is inflammation of the lining of the joint. After that, what would happen is I'd give you some lab work. We do some investigations, maybe some imaging, especially if the diagnosis is not clear. But once we have a diagnosis, we talk about treatment and we get you going and hopefully feeling better.
Wow, that's a very detailed approach indeed. So when you pick these patients up for the first time, do they usually present at a very sort of early stage of the disease, or do you actually sometimes pick up patients with quite late in their trajectory and with complications and whatnot? And what might those complications be?
Yeah, it's a good question. They're kind of all over the place when they come to us. I think there's some that present early and some that present late. It's of course much better to present early, because then we can prevent complications going forward of rheumatoid arthritis. Specifically, the most common complication of rheumatoid arthritis that is untreated would be deformities in the joints and chronic joint pain. And the whole idea behind treatment is to try to prevent those things from happening. But in addition, because rheumatoid arthritis is actually a disease that can affect multiple things in your body, multiple organs in your body, we're also trying to prevent complications elsewhere in the body other than the joints. For example, people with high inflammation in their body are at higher risk, as you know, of cardiovascular disease. Rheumatoid arthritis can also affect your lungs, so you can get fibrosis in your lungs and problems in your lungs in that respect. But also, people with really severe rheumatoid arthritis can have a problem in their neck, and it's really important to treat that, because then you run into issues with the spinal cord and dangers in that realm. So very, very important to catch rheumatoid arthritis early, to get people on treatment early so that we can prevent those complications down the line.
Wow, so it can get quite involved if other organs are affected, sounds like.
Yeah.
So yeah, so when, like, anyone, a nurse practitioner, a family doctor, or even specialists like myself, when we make a referral to you guys to rule out or diagnose or treat rheumatoid arthritis, what kind of workup would you want us to have prepared for you to make things easier?
So there's lots of things that you can do to sort of speed up the process. Of course, doing your own assessment and telling us what you found and why you think the patient has rheumatoid arthritis is always very helpful. But if you were able to order baseline blood work, as well as some of the rheumatoid arthritis blood work, so an RF or an anti-CCP, those are very helpful. Also, markers of inflammation, such as a C-reactive protein, would be very helpful. And then any images that you can get of the joints that are affected is also very helpful. So most people would start with X-rays, and so if you're able to get baseline X-rays, then we can usually take it from there. If you are feeling more adventurous and you want to get an ultrasound of the joint, that's always helpful as well. But I would say if you did X-rays, that would be just fine.
Yeah, anti-CCP, that's a Royal College exam question for
Yeah,
medicine. Yeah. Haven't heard of that for a long time.
Yeah,
shows you how much we remember. No, that's great. Thanks so much. With regards to treatment then, so once the patient has been diagnosed, what's the algorithm or the pathway that you get them onto?
Yeah, so the first thing would be it's always important to discuss with the patient what they want in terms of treatment and what their treatment goals are. We would always talk about what our concerns are and the treatments that we would suggest, but at the end of the day, it's always up to the patient as to what they want to do with their own body. So we're there to advise and to provide recommendations, but we always take patient preferences into account. When we look at treatment for rheumatoid arthritis, there's sort of two avenues that we look at. One is to settle the joints down or to settle the inflammatory process down quickly. And then the second part of it is to make sure that it stays controlled in the long term. To settle joints down quickly, often we'll use a corticosteroid such as prednisone, which we can give by mouth or by intramuscular injection. And that will settle the joints down quickly. But that is not a sustainable long-term solution because there are long-term impacts of prednisone if you're on it for too long. And so after we settle the joints down with prednisone, what we'll often do is we'll put patients on a medication in order to keep them in control in the long term. Most commonly, the first medication that we would use is methotrexate. But if, for example, you have other medical conditions that would preclude you from taking methotrexate, we may use something else like hydroxychloroquine, sulfasalazine, or leflunomide. Once you progress down the line, and if these initial medications are not enough for you, there are fancier, more targeted medications called biologic medications, which we may talk about in the future as well. But most commonly, the first line treatment for rheumatoid arthritis is methotrexate.
Wow, so that's a lot to know and remember. Certainly is a very complicated disease, and takes a lot of work and between the expert like you and also the patient to work together. to make things work. So thanks so much, Dr. Amlani, for joining us today. We've learned a lot, and we hope to invite you back again next time.
I would love to be back. Thanks for having me.
Thanks. Have a good day.
Bye.
Bye.